Welcome to Cold Steel, the Canadian Journal of Surgery podcast, with your hosts Amir Farouk and Chad Ball. The goal of the CJS podcast is threefold. The first is to highlight the best research currently being completed by Canadian surgeons. The second is to offer educational topics for both surgeons and trainees alike. And most importantly, the third goal is to inspire discussion, thoughts, creativity, and career development in all Canadian surgeons. We hope you enjoy it.
Hi everyone. In this episode, we had the opportunity to talk to Dr. Shahzeer Karmali. Dr. Karmali is a bariatric and MIS surgeon at the Royal Oaks Hospital in Edmonton, Alberta, and we talked to him about post-bariatric complications and things that every general surgeon really should know how to manage if they see these patients on call. In addition, we got to talk to him about some really interesting research that he's done related to intra-cranial hypertension, and finally closed off by talking about what it means to have a relationship with industry and doing research. We hope you enjoy.
Thanks so much for joining us on Cold Steel, Dr. Karmali. We know it's kind of a crazy time, and everyone's quite busy dealing with all the issues that surround COVID. So thank you in advance. For viewers that are, I should say, listeners that don't maybe know you as well as we do, tell us where you grew up, what your training pathway was, and maybe why you chose bariatrics at the end of the day.
Yeah, sounds good, Chad. Thanks for the invitation. I really appreciate being on the Cold Steel podcast today. So I was actually raised in Edmonton, Alberta, and I did my medical school in Edmonton. Thereafter, I did my residency at the University of Calgary. Following that, I did fellowship training at the Baylor College of Medicine in Houston, Texas. My fellowship was focused on minimally invasive surgery as well as bariatric surgery. Thereafter, I've taken up academic position at the Royal Alexandra Hospital, which is affiliated with the University of Alberta in Edmonton. As to why bariatrics, I didn't have too much exposure to bariatrics during my medical school, nor during my residency. It was more of an interest I had in minimally invasive and laparoscopic surgery, but as I entered my fellowship, I had an ability to really get immersed in a world of, bariatric surgery, and it really fascinated me because it's one of the, first of all, as a surgical operation, it's quite a challenging laparoscopic operation, but more than that, the patient cohort was really interesting because you're dealing with, individuals who are suffering from severe obesity and a lot of the comorbidities associated with it, and you see the impact you can have by applying this tool called bariatric surgery and not only improving their health, but improving their quality of life, their quantity of life, and the most interesting thing is improvement of comorbidities. And as we know from major studies like the Stampede trial, bariatric surgery, especially surgery like a gastric bypass, has been shown to be a cure for conditions like type 2 diabetes, which is amazing. You're using a surgical operation to treat a medical problem. So that's kind of what generated my interest in bariatric surgery and kind of keeps me going in that field currently.
Yeah, I think it's kind of neat. Both you and Scott Gamora have now been on the podcast, and we talked to Scott about surgical training and kind of the interesting way that we do that. But both of you guys came out of a residency that really didn't have much bariatrics at all, and both of you guys have become such great national leaders. It's pretty awesome to see. To that extent, then, when we look at the Edmonton group from the outside, you guys have been really productive on the academic bariatric side. How have you done that, and how do you view that, and what makes you guys really honestly stand out from most of the other groups in the country?
Well, I think the main thing, in learning about bariatric surgery and with most other surgical disciplines, you realize that, evidence and publishing and really getting your name out there helps with recognition as well as maintaining your association with other centers. So we really got immersed in this idea of the MBS QIP, which is equivalent to the NISQIP. And what it is, it's a cohort of bariatric surgical centers that work together to share outcomes, share data, share research in a common goal of providing high quality care and management to our patients. So part of that care goal is obviously to study our outcomes, study what we're doing, and use methods to improve our overall quality of care delivered. So in essence, by being involved in such a large consortium, it really drives us to not only provide good clinical care, but study our care, research our care, and publish what we do. So that's really what drives it, and I think everybody's bought into that idea. And this MBS-QIP idea really propagated in the U.S., and it's starting to kind of grow in Canada now. So there's more and more centers that have got on board to this MBS-QIP idea, and as we hope as centers develop in Canada and really get integrated into that, they can add to the research engine, in Canada especially.
That's awesome, Dr. Karmali. As one of the R5s who supposedly is going to be writing his exam at some point, yet to be defined, but at some point we are going to write that Royal College exam. I thought that would be really useful for us as well as for anyone who might have to deal with bariatric patients, perhaps on call, etc., to talk a little bit about some of the common things that you can expect from a bariatric patient in terms of complications. And maybe I thought it would be useful to just have you define the problem of obesity in Canada, as your group has written a lot about that. Like, how big of a problem is obesity in Canada, and to what extent is bariatric surgery really caught on in the country?
So, I mean, obesity is an interesting condition because, in the past, obesity was just seen as, not necessarily a cosmetic problem, but people being overweight and just not looking good and just having some extra pounds. But as kind of evidence and research has developed, we realized that obesity itself and has been classified as a chronic disease, and especially severe obesity. So that's the obesity that we tend to deal with. So those are individuals who have body mass indices of over 40 or body mass indices of over 35 with obesity-related comorbidity. So these are the severely obese patients, and these severely obese patients really suffer. So a person who has severe obesity usually has about a 10 to 12-year reduction in overall life expectancy as compared to individuals who don't. And as I mentioned, severe obesity, being a chronic disease, is closely linked with other chronic diseases. So people who are severely obese aren't just obese. They're usually also type 2 diabetic, suffer from high blood pressure, high cholesterol, COPD, sleep apnea. The list goes on and on. So there's this big congregation of this chronic disease entity of severe obesity that's kind of evident and permeating, nationally and internationally. Now, when we look at Canada itself, so what percent of the population would be considered to be severely obese? And there's different ranges in different provinces, but on an average in Canada, it's probably around 25 to 30% of the population is considered to be on that severe obese spectrum, which is huge, right? Like that's a large number of individuals who are suffering from this chronic disease condition. And so because of that, a lot of centers have developed to facilitate management of it. Now, bariatric surgery, when we talk about management, is a tool, and it's a tool used to manage this severe obesity. And, how much bariatric surgery is being done? Well, interestingly, although 30% of the population is severely obese, probably only about 1.5 to 2% of those individuals actually go on to have bariatric surgery, because there's an access problem too. There's, when I look at countrywide, there's probably only around 15 bariatric surgeons offering bariatric surgery across the country. So there's obviously a supply and demand imbalance going on right now.
And obviously bypass and sleeves are probably the most common operations, but is there anyone doing some of the other operations, and maybe you could actually describe the differences between let's say a sleeve versus a bypass versus some of the other lesser known things like a duodenal switch or biliary pancreatic diversion?
You bet. So in terms of operations being done, so in Canada there's probably 3 common operations being done. The gastric bypass is probably the commonest. The gastric sleeve, which is a close second, And then there's other operations, variants of the duodenal switch or single anastomotic duodenal procedure. So those are the commonest three. In the past, there was an operation very commonly done called the adjustable gastric band. It's not really being done anymore in Canada, but it's an important operation to know about because there's a lot of individuals who have issues or complications with that operation. In the U.S., our partners down south, interestingly enough, the commonest operation is actually the gastric sleeve, followed by the gastric bypass. So I guess to your question, just to go through the operations, I can just kind of go through each kind of in general in terms of, what they look like, what they do, and then we can talk a bit more. So just starting with just to get it by, because I did mention is the adjustable gastric band. So this operation really became very popular kind of in the late 2000s and really tapered off, by 2010 to 2012. But there was a lot of adjustable gastric bands being done. What the adjustable gastric band is it's a silastic band that is attached to a port, and it's kind of like a portacat. So when you fill that port with saline, the band has a reservoir, and that reservoir gets tighter and tighter and tighter. And so what the operation did was that surgeons placed this adjustable band in the upper portion of the stomach. And what it did was it created essentially a reservoir at the top of the stomach. So there was the band was sitting, so you got food coming down the esophagus, and before it filled the entire stomach, it filled as a reservoir above the band. And when it filled a reservoir above the band, what happened is that people who had this band in felt this kind of idea of fullness. So it's kind of fooling your body into a portion control reduction. So people are like, hey, I'm eating this food and I can feel full on less food. So what happened is, for example, if somebody eats 5 cups of food to feel full, with the band in place, they're eating 1.5 to 2 cups because it filled this reservoir first, and they're like, hey, I feel full, and that's what facilitated the weight loss. So that's how the band worked. The issue with it is that to really get the band to work, patients had to come in and keep having the band filled and adjusted to a point where you could reach this kind of green zone or a happy medium where you got that fullness. And the problem that came about is that it required a lot of effort to do it. A lot of patients didn't follow up. A lot of surgeons were just doing the band and losing patients to follow up and not really following the protocols that had to be followed. And so because of that, there was a high failure rate with the band. Right now, probably around 50 to 60% of patients who've had a band have now had it removed because it just didn't work. So that's the nuts and bolts of the mechanism of action of the gastric band. Again, not being done very frequently. In terms of the next kind of operation is probably in terms of, and I'm doing it kind of by rungs of complexity. So the next one is probably the gastric sleeve. So the gastric sleeve is an interesting operation. This operation probably started really picking up interest kind of in 2006 to 2007. It was initially done as a staged operation to another operation, which I'll discuss in a little bit, called the biliopancreatic diversion duodenal switch. But what happened is that when patients had this initial operation called a gastric sleeve, a lot of patients started losing weight. So surgeons said, hey, let's think about doing this gastric sleeve as a standalone operation. So that's kind of where it developed. Now, what the gastric sleeve is it's essentially a restrictive operation where surgeons use surgical staplers or other methods, and they work to decrease the reservoir size of the stomach. So, for instance, if somebody has a stomach that's usually, tell patients, your stomach's probably the size of a small watermelon. What happens is that surgeons use surgical staplers or other techniques to change the configuration and size of the stomach from a watermelon to probably the size of a large banana. And by doing that, by decreasing that reservoir size, what happens is that patients get that portion control reduction. So same kind of idea, they feel full on less food. So rather than eating 4 to 5 cups of food per meal, they can eat 2 to 2.5 cups and feel that feeling of fullness. In addition, there's some secondary effects that also happen with the gastric sleeve, which kind of came about with research. And people found that, after the gastric sleeve, not only were people getting this kind of portion control reduction, they were also finding their hunger urge reduced for some reason. This wasn't seen with the band. And as research started developing, they found people found that people who have a gastric sleeve start noticing that their hormonal levels of a hormone called ghrelin have also diminished. And the reason for that is ghrelin is stored in your gastric fundus, and with the gastric sleeve, that gastric fundus is removed. So lo and behold, patients who have a gastric sleeve have lower ghrelin levels. And ghrelin is a hormone that drives hunger. So when you drop ghrelin levels, your hunger urge also diminishes. So it's kind of a dual effect. So it's very interesting. The gastric sleeve is a good operation. It results in pretty decent weight loss. We usually quote around 50 to 55% excess weight loss with the gastric sleeve. So it's pretty strong, pretty robust. The issues with the sleeve are that the stomach is a very pliable organ, and if patients don't follow appropriate dietary recommendations, that stomach can stretch back up. So there's probably around a 5% failure rate that we quote with the sleeve. And finally, the one concern with the sleeve is because we are reconfiguring the stomach, we're always concerned about changing the orientation of the upper esophageal area or the angle of His or the gastric reflux mechanism. So some individuals who have a lot of reflux pre-existing can get worsening reflux after a sleeve. So that's always the one concern with the sleeve is gastric reflux. The next operation in terms of complexity is the gastric bypass. So the gastric bypass, like I said, the sleeve has probably been done since 2007. I mean, the gastric bypass dates back to the 1960s when it was done as an operation. It's obviously changed in the way in which we do it, the fact that we do it laparoscopically now, but the idea and the philosophy of what it does and how it works remains the same. So with the gastric bypass, a couple things happen. So the first thing that happens is that when you look at the gastric bypass or a picture of it, you'll see that we form a little pouch, right? So we take the stomach and we form a pouch from the stomach using a stapler. So rather than food filling your entire stomach, it fills this pouch. So by filling the pouch and not filling your entire stomach, you get that same reservoir effect. You feel full on less food. So similar to the band, similar to the sleeve, they get that portion control reduction. The difference, though, with the gastric bypass is rather than having the food just enter into the rest of the stomach, we actually bring up a loop of small bowel called the jejunum, and we join it to that gastric pouch. And what happens is that the food travels down this loop of jejunum for a variable distance, depending on centers, but usually on average about 100 to 125 centimeters, before it reaches the biliopancreatic secretion. So the reason this operation is called the gastric bypass is what we're doing is we're bypassing your food from seeing your biliopancreatic secretions. There's not a huge bypass of stomach or bowel from seeing food, because really the only portion of your intestinal tract that's not seeing food is your remnant of your stomach, and probably around 20 to 30 centimeters of duodenum and jejunum. However, your food is not seeing the secretions from your pancreas and your biliary tree right away. It's getting more time. And as that happens, different things happen. So this is where the interesting stuff comes with the bypass. This is where a lot of literature is still kind of determining exactly how does this bypass work. We know it causes restriction, but it also causes changes. And there's a lot of neurohormonal changes that we're seeing happen with the gastric bypass, where there's shifts in different neurohormones, especially neurohormones that drive weight and neurohormones that drive type 2 diabetes. Important ones are things such as cholecystokinin, ghrelin, incretin, and all these hormones start changing and varying. And by doing these sort of things, we find that these neurohormones diminish. And by diminishing these things, patients notice weight loss as well as improvement in comorbidities. And so when we talk about numbers, with the gastric bypass, people are now pushing much higher weight loss because you have this dual restrictive effect and neurohormonal effect. And so patients are pushing around 70 to almost 80% excess weight loss, and much more stable and much less variable because you've got this kind of dual effect happening. So that's the gastric bypass. And finally, the biliopancreatic diversion duodenal switch. So I'll just temper the fact that this operation isn't performed very commonly. When we look, nationally, it probably represents 0.5 to 1% of all operations being done. It's quite a complex operation, but in general terms, what this operation is it's a combination of a gastric sleeve. So we do a sleeve gastrectomy on the stomach to make it smaller, and then we essentially create a malabsorptive operation. So the bypass isn't necessarily a malabsorptive operation. This is a malabsorptive operation. So for this operation, we essentially join a loop of usually distal small bowel to the stomach, and then we reanastomose that to ileum. So it causes a large malabsorption in your small bowel. So in this operation, most of your small bowel, from your duodenum to a large portion of your jejunum, is not seeing food. And the only portion of your bowel that's seeing food is that sleeve portion of the stomach, probably around 50 centimeters of distal jejunum and ileum, and then over to your colon. So really a really high malabsorptive operation. And it's this malabsorption that causes the weight loss. And the weight loss with this operation is really high. Patients can get around 90% excess weight loss, very, very high. But it comes with some consequences because people also experience a lot of malabsorption. So people usually have to be on a lot of multivitamins, a lot of minerals, and you have to be very careful with these patients because they can be really malabsorptive after this operation. And it's because of that this operation hasn't really been adopted nationally or internationally as the most commonest operation that we do. So
that was an awesome overview of the operations, and that was excellent. I was wondering if you could talk a little bit about what the pathway is for patients in your hospital. So they come in for their, let's say, their bypass. What do you do in terms of their swallow? When do they get discharged? And what kind of medications and things like that do you put them on post-op?
Sure. So post-operative care?
Yeah.
Yeah, sure. So there's different. I'll focus on the bypass and the sleeve as the two key operations. I'll tell you kind of what we do and in general what the outcome is. So with both operations, we do both operations laparoscopically. In our center, we admit all patients after the operation for usually a period of 24 to 48 hours. In terms of imaging after the operations, there's debate about the utility of upper GI series post-operative day one to assess anastomoses or assess the sleeve. Really, there's no good evidence to indicate that these studies are useful. So, I don't think they're necessary as a post-operative tool. Some surgeons do like to use them just for their own safety or sake, but there's no good evidence that an upper GI series is needed post-operation to rule out a leak. We do a lot of intraoperative testing. That's been proven, so we intraoperatively use endoscopy to assess anastomoses with saline and methylene blue dye, and as long as those are normal, the chance of leak is usually diminished quite substantially. So after the operation, the patients are usually admitted to the floor and plus or minus a fluoro post-op day one, and thereafter they're usually started immediately on a progressive diet from clear fluids to a bariatric full fluid diet and then over to discharge. So most patients are discharged either post-operative day one or post-operative day two. We usually really try to maintain patients to be up and about and moving, so we tend not to keep them on bed rest. We don't use Foley catheters. We take off any compression garments after the operation and really get them moving. In terms of post-operative medications, there's a couple key ones that we put patients on, which is similar for both operations. We put gastric bypass and gastric sleeve patients on Pantaloc, and we put them on a dose of about 20 milligrams BID, or sometimes 40 milligrams BID for a period of 6 months. And the reason we do that is to prevent the formation of marginal ulcers. There's been evidence show that there's a higher risk of marginal ulcers, especially after a gastric bypass operation, and marginal ulcers can cause problems, so we leave patients on Pantaloc for 6 months after the operation. The other medication we have started to put patients on also is Urso or Actigal or ursodeoxycholic acid for patients who haven't had previous cholecystectomies, because we know that with rapid weight loss comes increased risk of gallstone formation, and we really don't want our patients to have symptomatic gallbladder disease after having a gastric bypass or a gastric sleeve. So patients also go on Urso or Actigal if they haven't had a cholecystectomy for a period of 6 months. And finally, we just place patients on regular pain medication, not too much. We usually give them either a codeine elixir for about 7 days or Tylenol elixir strength for 7 days. We really discourage the use of non-steroidal anti-inflammatory drugs because those can predispose to ulceration and gastritis. So we don't promote the usage of NSAIDs post-surgery.
How about heparin? Are you sending people home on heparin?
We're not. No, we're not sending people home on heparin. We do obviously use heparin post-operatively in the usual post-op surgical period, but we don't send patients home on injections of enoxaparin currently.
Okay, awesome. Something that seems to come up on exams a lot is talking about a variety of kind of bariatric complications, and I thought we could sort of look at this from an early or a late type of phase. So, you get, let's say you have a bariatric patient who's post-op day 1, their hemoglobin is dropped or they're tachycardic, and you think they might be bleeding. How do you kind of approach that?
Yeah, so I mean, I think just at the outset, I think as we look at Royal College exams or exams in the U.S., we're seeing more and more bariatric complication questions being more evident because it's a real deal. Like I told you, the amount of individuals who are obese and the more and more bariatric surgery they were performing, even if you don't do bariatric surgery yourself or you don't believe in it, you're going to see a patient who's at least had bariatric surgery in your hospital or out in the community. So when we look at complications, like you said, I mean, it's good to focus initially we'll focus on the post-operative complications first, and then we can look at, patients who are discharged. So post-operative complications, the commonest ones we see, somebody who's had, for instance, a gastric bypass or a gastric sleeve, so is, number one would be hemorrhage, right? So hemorrhage, obviously it's a condition that can happen after, either of those two operations. Some people put a Jackson-Pratt drains in, which can be, a monitor. It obviously won't prevent a hemorrhage, but if you see, obviously, a Jackson-Pratt drain filling with blood, then that's obviously an indication to be worried about. So when we look at bleeds, an easy way for me to understand or classify it or figure out how to deal with it is, first of all, determine whether this is an intra-abdominal bleed or an intraluminal bleed, right? So, for instance, if you have somebody who's had a bariatric operation and they're convalescing on the floor and suddenly you notice that, hey, their hemoglobin is dropped or they're experiencing some signs, obviously you assess the patient and determine, okay, now what's going on? Is this, there's probably a bleed going on somewhere because I'm not sure why the hemoglobin is dropped. The first thing is obviously check the patient parameters. I mean, if they're hemodynamically labile, like they're hypotensive or tachycardic, especially tachycardic, then obviously that's significantly concerning. So obviously start your resuscitation efforts, start fluid, start blood as needed, and then get to the idea of figuring out, where this is coming from, what I need to do. If I have somebody who's hemodynamically labile or unstable or tachycardic, and I'm worried about a post-operative bleed, then usually my next step is taking that patient back to the OR for usually a combination of things, usually a combination of a diagnostic laparoscopy plus or minus an intraoperative gastroscopy. If they're tachycardic and you're worried about a bleed, especially after a bariatric operation, our threshold is pretty low to take them back to have a look on the inside and have a look on the outside. So that's the first thing. If they're hemodynamically stable, and then you say, okay, you know what, they're hemodynamically stable, post-operative day 1, suddenly, well, why does the hemoglobin level drop down from, 120 to 90 or 80, but they're stable? So this is now where you get into the investigation of, okay, is this intra-abdominal or is this intraluminal? Because that can change what you do. And that, this is where sometimes a drain can help you. If you have a drain in and, there's no blood in the drain at all, then maybe you're thinking intraluminal, or if the drain is full of blood, you're like, maybe this is an intra-abdominal bleed. If you don't have a drain in, then obviously you have to do a bit more history taking and figure out what's going on. Is the patient experiencing, if you have an intra-abdominal bleed, I expect at least some sort of discharge from some of the ports with some blood, or some skin changes may indicate an intra-abdominal bleed, or maybe some tenderness. If they have an intraluminal bleed, again, they may manifest with hematemesis or even melena. So this can kind of lead you to your next steps. If it's an intraluminal bleed, we usually try to, settle it down as much as we can with reversal of any anticoagulant medications, plus or minus potentially adding in blood products as needed, and if not, then switching to endoscopy to manage it. If it's an intra-abdominal bleed, then again it depends on where we're sitting in terms of the patient. If the patient is obviously in a lot of distress and discomfort, then sometimes the best thing to do is take them back laparoscopically and evacuate the hematoma. If they're fairly reasonable, usually these hematomas will resolve and we'll leave them alone. So again, managing an hemorrhage is similar to probably hemorrhage after any operation, but just understanding whether you think it's intraluminal or intra-abdominal.
Awesome. And then I think the other big one, obviously, that we'd be worried about in the early postoperative phase is a leak.
Yeah, so leak is probably the big one that you're probably going to hear about. And leaks are always hard. And the problem with leaks is that the take-home message for any resident or fellow or community surgeon is, if you think they even have a leak or you're worried about a leak, take them back to the OR. That's the end message. But in the end, what ideas would lead you to think about that? So the main thing we look at with leaks for patients is obviously you don't want to wait till they're manifesting signs of sepsis. So using corollary markers like a fever, an elevated white blood cell count, abdominal tenderness, peritonitis, usually too late. So we don't tend to use that as a caveat. And interestingly, the main caveat we use is actually heart rate, which is very interesting because studies have looked at different parameters for a leak and what parameter is the most consistent in terms of potentially diagnosing a leak. And what they've shown is that patients have had, especially a gastric bypass, if somebody's had a gastric bypass and post-operatively there's a run of sustained tachycardia of a heart rate of over 120, which is sustained for a period of 2 to 3 measurements or 1 to 2 hours, a sustained tachycardia of over 120, there's a higher than normal likelihood that something has gone on, like a potential leak in the abdominal cavity. Now, that tachycardia could be from bleeding, so you have to obviously sort that out. But I think if you've seen a patient, or if my fellow comes to me and said, hey, listen, we did a gastric bypass on this lady at around 2 p.m., I'm seeing her at 10 p.m., she's had this kind of sustained tachycardia after the operation, what should we do next? Should we, do an upper GI? Should we do a CT scan? Should I watch her for a couple hours? Her physical exam is pretty unremarkable. The answer to that question is take her back to the OR for a diagnostic laparoscopy, period. End stop. That's the answer. So that is what needs to be done. And the reason it needs to be done is that because patients who have bariatric surgery or severely obese, they can really mask symptoms of sepsis. So to wait for a patient to get abdominal pain, you may have missed that window, and they can, circle down the drain proverbially pretty quickly, right? And it's very hard to catch up. And taking them to an OR for a diagnostic laparoscopy is very quick. You have a look. If there's no leak, then you're good. If there's a leak, you can put a stitch in. There's not too much contamination, and you can move on. So, we have that as our protocol. If somebody has a sustained tachycardia of over 120 on repeat measurements, then the next call is to the fellow and to the staff surgeon, and usually we're back in the OR having a look.
Let's talk about that operative approach. Let's say you're in the operating room and you see a leak. I guess the places that you could see a leak would be, off the staple line, off the anastomosis, etc. Is there anything that you would do differently depending on where the leak came from?
Yeah, I mean, if you have a leak, the commonest point of a leak for a gastric bypass is usually at the gastrojejunal anastomosis. That's usually the commonest place that you'll see the leak, and that's where the leak happens. It's usually right at the anastomosis. So again, it depends on when you're seeing it and how much contamination there is. So obviously this is all intraoperative decision making. So if you get in there and there's not too much contamination, again, we liberally use endoscopy quite a bit. So you put an endoscope in, have a look. If you see a little bubble coming in, then what we try to do is essentially try to stitch the leak point up. So we'll do intracorporeal suturing, suture the leak up, so close the hole back up. After that, then it depends on surgeons. Some surgeons say, okay, I've got the leak sutured up, and then a lot of them will place a piece of omentum, almost like a Graham patch, over that sealed leak area. so just to buttress it. And thereafter, obviously, drain the area quite well. So most people will put a couple of Jackson Pratt drains around the area. The last thing is if I see a leak, and usually most of my colleagues, if we see a leak at the gastrointestinal anastomosis, you want to have this area healing, and you want to be able to feed the patient. So most of us, if we're seeing a leak and we manage a leak with a suture or a buttress, we'll usually liberally place a gastrostomy tube into the gastric remnant. And by placing it into the gastric remnant, it allows a source of feeding, right? Because by accessing the gastric remnant, you can now feed the patient to the gastric remnant, and that feed will go, down the duodenum, past the jejunojejunostomy, into the common channel, into the rest of the small bowel. So you can actually let that anastomosis, heal, not put any food through it, feed the patient, and give it time. So most of us, if we get in there for a leak, will either suture the hole closed, put a patch over top of it, drain widely, and then do a gastrostomy tube. And that's usually the main principles of managing a leak. If you get in there and there's a huge hole and you can't suture it back together, obviously it's hard to manage. So at that point, usually we go into a bit of a damage control situation where we try to cover at least the hole with a piece of momentum, wide drainage, do the gastrostomy tube, and leave it alone. Again, like most leaks, it should heal. Let it decompress, put a gastrostomy tube, feed the patient, and then move on.
Gotcha. Because usually the leak will not be at the jejunojejunostomy, because that's a small bowel anastomosis.
Yeah, very uncommonly to be at the jejunojejunostomy. Obviously, it's not impossible. Most commonly it's the gastrojej, but if we get in there and the gastrojej looks okay, obviously we always check both anastomoses. So we'll check the JJ. If it's there, then usually same kind of ideas. We'll suture it up.
So for an early leak, do you ever consider doing things like stenting, or does that ever come into your management, or it's always going back to the operating room?
No, for an early leak, always back to the operating room.
I think that's a good segue to talk about maybe perhaps some of the let's say the discharged patient who now comes back in with some issues. And maybe we could stay with the leak. Let's say someone, like I actually saw someone recently who came back 2 weeks post bypass with kind of just malaise and a fever, and got a CT scan done by the emergency department, which showed an abscess in the left upper quadrant. How would you sort of deal with that situation?
Yeah, so late leaks are the other big issue. So late leaks, again, I think the best way to understand this, let's separate the operations to a gastric bypass and a gastric sleeve. And I didn't really talk about an early leak after a gastric sleeve. It's quite uncommon, but again, if that happens, and somebody who has a gastric sleeve who has an early leak, same kind of principle, take them back to the OR, find the leak point, usually in the sleeve. It's usually in the sleeve staple line, oversew it, put a drain right next to it, and consider distal feeding access. For that, there's no gastric remnant, so usually a feeding tube into the jejunum somewhere. So that's just to get that out of the way. So now, late leaks. So late leaks is somebody who's, let's say, been discharged home and comes back to the hospital. So same kind of principle. Let's just deal with the bypass first. So if you have somebody with a gastric bypass comes back in and, you're worried about a leak again, depends on stability of the patient. If they're unstable, signs of sepsis, looking unwell, then take them back to the OR and see what's going on, okay? So you have to get in there, drain the surgical goals are obviously drain the contamination. So if there's a leak, try to suck out all the enteric contents, clean it out, wash it out, try to figure out where the leak is coming from. If you're in the OR and they're unstable, usually at this point at 2 to 3 weeks, it's usually quite hard to suture anything back up because the tissue is probably quite friable. So it may come to a point of just draining, trying to patch what you can, and get feeding access. Right. Most of the times, though, these late leaks are stable, kind of like your patients, where they come in, they kind of look unwell, but they're not hemodynamically unstable. Maybe a bit of a fever, maybe a bit of a white count. And then you do some imaging or you do some x-rays and you say, hey, there's a bit of a collection going on. So how do you manage those? So the main management for those is, again, same kind of idea. You want to deal with the infected collection. So if there's an abscess, drain the abscess, get some sort of feeding access if you can. Obviously, it can be kind of hard, but a lot of times we can get our interventional colleagues to put a CT-guided or ultrasound-guided gastrostomy tube into the gastric remnant. And as soon as you've got that done, you've got time on your side. So you drain the abscess, drain the collection, and you start feeding access, and then you're good. Then the point is, how does this leak heal? And usually after a gastric bypass leak, as long as it's drained, controlled, you feed distally, usually tincture of time will allow that leak to heal. If it doesn't heal, then usually we tend to use more interventional endoscopy techniques to facilitate the leak healing, and those can be things such as intraluminal suturing, sometimes clips, sometimes using adjuncts like internal drains or intraluminal injection of sealing agents, or in some situations putting a stent across that anastomosis. We're kind of worried sometimes about stenting across gastric bypass anastomosis, because the problem with the stents there is that it's such a small area, and with stents there's risks of stent migration. So we will stent bypass leaks, but that's usually lower in our algorithm in terms of managing them. In terms of sleeve leaks, though, totally different. So with the sleeve leaks, the same kind of idea. If you have somebody who has a sleeve that comes with a leak, if they're unstable, don't look good, then again, take them to the OR, wash out the contamination. At that point, what do you do? So for sleeve leaks, stents are a great option for late sleeve leaks. It works really, really well. And the reason it works well is not necessarily that the stent seals a leak, but it seals a problem with the pressure in that remnant stomach. Because a lot of patients who have sleeve leaks, the issue is there's this issue with high pressure, because with a sleeve, you're making the stomach much smaller. And as we know, with Poiseuille's law, as you decrease your radius and your diameter, your pressure increases, right, exponentially. So with a stent, what it allows your stomach to do is it decreases the pressure in your stomach and allows the flow to go up into your esophagus or down to your duodenum. And by decreasing the pressure, allows that area to heal. And most sleeve leaks won't heal without that pressure diversion. So with sleeve leaks, stents are kind of the number one thing we do. So intraoperatively, if it's there for somebody who's unstable, we drain the collection, and then we put a stent in. For somebody who's stable with a sleeve leak, same kind of idea. We'll drain the collection usually non-operatively with a CT or an ultrasound, and then send them for stenting to seal that area, or more importantly, decrease the pressure in the area to allow that area of sleeve leak to heal up. And most of them, interesting enough, heal up after a period of stenting.
That's awesome. So stents are your friends for sleeves, and then there's kind of lower down in your algorithm for bypass leaks.
Correct.
Okay, awesome. And then I think the other huge topic is the bypass patient who comes back with an obstruction.
Probably the biggest question that you'll probably, residents or community surgeons will get is this kind of idea of somebody who has a gastric bypass and comes to the emergency room with, especially a laparoscopic gastric bypass, and comes to the emergency room with signs and symptoms of intermittent abdominal pain, and then is kind of feeling bloated, and there's worry about an obstruction, whether it's abdominal distension or they do 3 V's of the abdomen and there's dilated loops of small bowel. So we know what's going on, what's the next step. So the major concern, and this is again one of those big areas of bariatric surgery, is the idea of internal hernias, right? And an internal hernia, in essence, is where you get a loop of small bowel going to an area where it's not supposed to happen. And with a gastric bypass, there's usually 3 areas where internal hernias can happen. The first area, and the commonest area we see currently, is an intermesenteric internal hernia, and this happens at the jejunocejeginostomy because we're creating a jejunocejeginostomy, and there's an area of a mesentery between the 2 areas of jejunum that we have to oversew. And sometimes that opening can weaken up, and you can get a loop of small bowel that pops through that opening. So that's an intermesenteric hernia there. Second hernia is called a Peterson's hernia, and that happens when we do an anticolic, which is the commonest one, an anticolic gastrojejinostomy. So there's always this area in the lateral aspect of the anticolic loop, between the anticolic loop and the transverse mesocolon, where there's a little bit of an area there called Peterson space, and you can get a loops of small bowel that can pop through that area. And the final one is a transmesocolic hernia, which happens if people do a retrocolic anastomosis and make a hole in the transverse colon mesentery, and you get a loop of small bowel sneaking through there. So the issue with these internal hernias, obviously, you get bowel that goes into these spaces, and And, if this bowel gets caught and it dies off, you've got a big problem because you've already bypassed sections of small bowel, and losing small bowel and something that's already been bypassed is a major issue. So for any patient who has a gastric bypass that presents with the signs of, intermittent abdominal pain, they usually say, I've had some pain off and on, and now I've got this more pain, and now I've got some bloating and distension. The key thing to do with this patient, the next step is back to the operating room. So there's always questions, hey, should I confirm this hernia with a CT scan or do an upper GI series? And the answer is no. A CT scan is a useful test. If you do a CT scan of somebody and you see signs of, swirling of the mesentery and a large predominance of small bowel in the left upper quadrant, well, that's great. That's internal. You have to take them back to the operating room. The problem with it is that the sensitivity of a CT scan for an internal hernia is around 80%. So it's about 20% of patients that you will miss with a CT scan because the CT scan may not pick it up. And if you miss it and you leave the patient and they go on to infarct that small bowel, that's going to be a major issue and a life-changing or life-threatening issue. So anybody who has any signs and symptoms of an internal hernia based on physical examination or index of suspicion, you take them back to the operating room. There's no role for any tests, whether it's a CT scan or an upper GI series, take them back to the operating room to manage it.
Once you're in the operating room, what's your approach? Because I've found that this can be quite confusing once you're in there. It's hard to tell what's what. Yeah, so the main thing, funny, I did internal hernia for non-bariatric patients. The key thing is where to start, because you go in there and you're like, hey, this looks like the surgeon just hooked this up backwards. I can't figure out what's going on. So the key starting point, I tell any surgeon, we have our own general surgeons that take back internal hernias if we're not around. The key starting point is starting distally. Start at the terminal ileum, because that's consistent. That's always going to be there. You haven't done anything with a gastric bypass to alter the anatomy of the cecum or the distal small bowel. So what you do is you start there, and by starting there, what you do is you start just running the bowel from distal to proximal. So you start kind of pulling that bowel and start running it. And what you start finding is as you start running the bowel, you'll start finding that you'll start reducing stuff. And as you start reducing stuff, you'll come to the point of obstruction. As you reduce stuff, you'll kind of start reducing the small bowel from the TI to the ileum to the jejunum, and then you'll come up to an area. The first area you'll come up to is like I said, the intermesenteric defect of the jejunal-jejunectomy. So if you're reducing bowel and you come to that point and you're like, hey, there's no bowel in there, then you keep going. And as you keep going, you're going to turn the corner, you're going to start reducing bowel, and then you come to the next defect, which is the Peterson's defect, where the rulum goes up. And you can see, is there any hernia there? You look, there's nothing there, then you're done. If they've had a transmesocolic or a retrocolic anastomosis, the last area you're going to run into is that area where the rulum goes below the transverse mesocolon, and that's your last place to look. So the key teaching point is start distally at the terminal ileum and run distal to proximal, and you'll always find the defect. And when you find a defect, if there is an internal hernia, then you close it up with permanent suture. That's the take-home message. And hopefully you're there before there's any infarcted bowel. On one last technical point on this, when you're doing your initial bypass, are you closing Peterson's?
Depends on surgeons. So interestingly, I don't usually close Peterson's defect. My colleagues do.
Gotcha. Yeah, I think the guys here are the same. They close the jejunal-jejunostomy, but they don't close Peterson's.
Yeah, the reason for that, the reason for that is that when you're closing Peterson's, you have to be very careful about making sure you do a complete closure of that lateral defect, because what we see in terms of publications for Peterson's defects is that there's actually sometimes more hernias if you close Peterson's not improperly, right? So you're making a big defect into a small defect, and that's where the problems come about, right? So I haven't normally closed Peterson's, but that might be debated, and people on the podcast might challenge me to that.
Shaz, that was absolutely fantastic, and thank you for that masterclass in bariatrics. We certainly need refreshers really at every level, no matter if we're super specialists or not. It's interesting, in my HPV job, we were just lucky enough to be in Calgary, part of a 4-country multinational, 28 multi-center study. it was retrospective, but it looked at patients that had previously undergone, in particular, Roux-en-Y gastric bypass and then needed subsequent Whipples. And it was a good reminder, number one, that these patients can get other diseases and will get other diseases as they go on through life. But number two, the result of that study that's out in JOGS, Journal of Gastrointestinal Surgery, was really interesting because no single center had very much experience with it. The busiest centers were 3 or 4 patients over many years. And then also the reconstructive options were clearly very broad, and the selections were almost as broad. Do you have any thoughts on that?
So interestingly, that study is very interesting, and it's actually changed bariatric surgeons, actually, that study, Chad. And the reason is this idea of the biliopancreatic limb, right? And previously, obviously the biliopancreatic limb where the turn of the duodenum happens and the distance between, where the distance of the biliopancreatic limb to the common channel, previously surgeons were making that pretty short, right? So right from, ligament of Treitz to the jejunoplasty, surgeons were keeping it pretty short, around 5, 10, maybe 15 centimeters. And obviously that makes it technically difficult for you, because if you go in there for a Whipples and I've only left you 10 to 15 centimeters and then you have a JJ, it'll make it pretty hard for you to get that resection done. So interesting enough, and for both reasons, people are finding that we're actually lengthening that biliopancreatic limb, both for that idea that if there's something else to be done, it gives you more opportunity to do it. And we've also found that actually biliopancreatic limb length, a longer biliopancreatic limb length, actually affords better weight loss. So people are lengthening the biliopancreatic limb to now, I usually go around 40 to 50 centimeters, and some groups has gone up to about 100 centimeters and actually decreasing their Roux limb length. So very fascinating idea. And like I said, bariatric surgery is just changing, and we're very adaptable to understanding that, there's no need to keep it as short because it may affect, non-bariatric surgeons in the future, and by making it longer, it helps both of us. So it's a very interesting article, and it's changed practice, right?
Oh, that's fascinating. Well, on behalf of all HPB surgeons and internationally, thank you.
You're welcome.
The other really interesting paper that you wrote in the Canadian Journal of Surgery and elsewhere, quite honestly, in a few different formats, was the idea of idiopathic intracranial hypertension in these morbidly obese patients, and that bariatric surgery is likely a treatment for a lot of that as well. Can you comment on that for us?
Yeah, so intracranial hypertension or benign intracranial hypertension, the other name for it is obviously pseudotumor cerebri, and we know that it's a condition when you look at the demographics of it. It typically affects young, overweight females, right? And we know that when they manage patients who have intracranial hypertension, when I talk to my neurosurgery colleagues, the standard of care for patients actually, obviously acetazolamide to decrease the pressure, but also weight loss. So they said, let's use this, fluid reduction technology as well as weight loss. And they found that, interestingly, when patients lost weight, their pseudotumor cerebri symptoms improved. The issue with just, regular weight loss going on diet and exercise is like all patients who suffer from severe obesity, it's hard to maintain that long term. And what tends to happen is that the amount of weight loss that's needed to really improve ICH is about a 10% overall excess weight loss, and very hard to establish with just dietary therapy. So what's gone on is that, hey, let's, what about bariatric surgery as a tool to just help with weight loss, but also maybe improve the symptom long term. And so what we did is we studied, what effect would bariatric surgery have on intracranial hypertension, and what we found, fascinatingly and that's kind of intuitively, is that patients who suffer from intracranial hypertension after bariatric surgery find relief of their symptoms, and more than that, almost complete resolution of their condition. So it's almost like a cure we're getting for a non-bariatric condition, non-gastrointestinal tract condition. We're getting cure of this intracranial hypertension, which is fascinating. We've had patients who've had, we know with pseudotumor cerebri, patients can have significant visual disturbances. And we had patients who were, at the point of not being able to see at all. And the concern was, these people are never going to get their sight back. And after, bariatric surgery and weight loss, their ICH improved, as did their visual disturbances, which were initially thought to be irreversible. So very fascinating, again, an area that's why, the idea of really researching and publishing things gets new ideas developed and understood.
Yeah, I couldn't agree more, Shaz. I mean, those are two perfect examples of, the interrelationship between multiple different subspecialties and specialties, quite honestly, and it's so important. Let's just finish on that note then, and I wanted to ask you specifically what your views are on sort of the pyramid relationship between industry, advanced MIS training, and the concept of innovation. And again, Scott Gamora and Amir and I had an interesting conversation about that sort of concept superficially. But you guys in Edmonton are known to be very linked to all three of those. So I was curious what your thoughts are.
Yeah, I get, with industry is always this concern about conflict of interest and, having industry involved and being too involved in what we do. And I take the other tack for it, because, we all work together and we all have a common goal. You have to understand, obviously, industry is there for business, but they also have an idea that by promoting good health, it'll improve what they do and what they offer. So we have a very, I say a symbiotic relationship with industry. And when we work together, we realize that by working together and sharing our ideas and thoughts and supports, we can work at, improving or improving care to our patients. So that's kind of our take on it. And, we work although, industry is involved in supporting our research, they by no means drive what we do or drive what we publish. A lot of the grants we get are obviously unrestricted educational grants. They put certain amounts of funds for grants that we can do what we want to do with them, whether the results are positive or negative, whether the results are related to their product or not. It's kind of the idea of promoting a good relationship between businesses with a common goal, and that's kind of the understanding, and that's also based on the ethics of research and being involved in a big center like yours and ours, where there's a stringent ethics process. There's a stringent process of looking at what we do and really having defined conflicts of interest. If I publish something that's industry funded, then I'll state it and explain what it is. So I think that's very, very important, and that ties into innovation too, because in the ability to innovate and grow and develop, you need that support, because you need support from a big business that can help with fostering innovation and putting forward ideas or putting forward new ideas or new products and help develop the next stages. And if you just shut them out, it's very hard, especially within Canada, to get the funding capability or the contacts to really innovate and develop. So that's kind of my idea. I think the idea of a symbiotic relationship is the most integral, and just understanding conflicts and having them out to people so they understand where you're at, and there's nothing kind of hidden behind the rug or behind the curtain.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you've liked what you've been listening to, please leave us a review on iTunes. We'd love to hear your comments and feedback, so feel free to email us at podcast.cjs@gmail.com or connect with us on Twitter @CanJSurge. Thanks again.